Okay, so we'd like to welcome you all to the very first BOMSS webinar, which is following on from the highly successful BOMSS journal clubs that have started in January. We are absolutely delighted to have Carel as our speaker, who Sharif will introduce shortly. But just wanted to point out that this series of webinars will be happening once a month going forwards with guest speakers on controversial topics. The session tonight was due to be sponsored by Novo Nordisk, but we have, for various reasons, decided that this evening's session will not be sponsored by them, and actually is being sponsored by BOMSS itself. Before we launch into the meeting, though, one really exciting bit of news is that with a little bit of leverage on Boris Johnson, we managed to get him to set government strategy so that the lockdown and social distancing officially end on the 21st of June, which just happens to be the date we've set for our next BOMSS scientific meeting in Oxford, the 21st of June, Monday, through to Wednesday, the 23rd of June. So please save those dates. This will be literally the first medical face-to-face meeting as we know and love them after coronavirus. So thank you, Boris. It was worth that pint of beer, and we'll see you all in Oxford on the 21st of June. Sharif.
Okay, so welcome everyone. So the first BOMSS webinar going on this evening. It's going to last until 8:45 as normal. So we've got 45 minutes, and it's my pleasure and privilege to introduce Professor Carel Roux. He needs no introduction, really. He just speaks for himself and his reputation, but we're really honored to have him speak tonight. So the title of his talk is Will Obesity Medications Be Gateway Drugs to Surgery? It's a really, really exciting topic, very, very relevant given the New England publication last week. So Carel Roux, after working in London and leaving Imperial, he now works in the University College Dublin. He holds a chair in experimental pathology. He's director of the Metabolic Medicine Group, okay? And he's going to be taking to us through his talk. Can I just remind you all to please post your questions via the Q&A function. We'll have a 30-minute talk and then around 15 minutes for questions. And just before we get started, the next journal club will be on Wednesday, the 10th of March, 8 p.m. And the brilliant Bristol team will be leading that. So please join us for that. So Carel, over to you if you want to share your screen, and we look forward to your talk.
Oh, thank you so much for that very kind introduction, and I'm very excited to be here. And I start with this famous painting that hangs in the National Gallery in London from Joseph Wright of Derby. And he depicted the Victorians thinking about science. And when I look at this painting, it's really reminiscent of what's happening today. So there's so much happening around the science of obesity and the clinical approaches that we have. But the responses of the population are very similar to what's depicted here. You can see there's some that's like the little girl at the front who's really frightened about these new developments, these new medications or these new surgical treatments that's coming out, and she's looking away. There's others like the man on the left at the front who's fascinated by it, and really mesmerized. And then maybe this is maybe David Kerrigan at the front here on the right-hand side, really thinking about what's the implications of this? How is this going to change, what we do? But what I would like us to be is like the little boy in the back who's opening up the curtain and shining light on the subject to allow us to really think about how do we, approach this, and, what will medication mean for surgery as we go forward. These are my disclosures, and we work with lots of different companies, with pharmaceutical companies, with surgical companies, with nutrition companies, because we don't actually think obesity is one disease. We think it's a multitude of diseases, and therefore we need more than one approach to it. And I think that's the important bit, that there's not going to be one silver bullet that is going to treat everybody that has obesity, but rather we need more tools in our toolbox. So this is the first famous paper published this year from Jaltrudi Mangrone and Francesco Rubino's group in the Lancet earlier this year, showing the 10-year data in a randomized controlled trial, and certainly showing that surgery is great for weight loss and glycemia. And what you will see on the slide on the left is how patients were able to lose weight, but also maintain the weight in the long term. And to remind you, this was a randomized controlled trial between gastric bypass and BPD. And what we then see on the right-hand side is what happens to glycemia. Again, people with very difficult to control diabetes, 8.5s on average, getting into remission, and therefore staying over 10 years in long-term glycemic control. And you can see also in the top, the best medicine arm, medicines are really good when it comes to the treatment of diabetes. But it's not good enough at the moment, because you can see despite the best treatments that we have with medicines and the vast improvements that we've had, surgery still outperforms medicine when it comes to glycemic control, when it comes to weight loss. But it tells us that, medicines are getting better all the time. And that is going to be a theme of today's talk. And now the question is, how is that going to impact surgery? Is it a threat? Or in fact, as I would like to suggest to you, I think this is an opportunity for bariatric surgery. Because one of the things that surgery is incredibly good at is not only weight loss and glycemic control, but surgery is great for quality of life and also for complications of diabetes. So what we are doing is we are now starting to shift the goalposts. It's not good enough anymore just to make somebody lose weight. It's not good enough anymore just to make the sugar better. Now what we need to do is we need to treat diabetes as a holistic disease. And of course, what you will see on the left-hand side is how good surgery is when it comes to quality of life over a 10-year period. And you can see on all of the domains, it outperforms medicine. But I specifically want to draw your attention to, the 1 o'clock and the 2 o'clock positions when we talk about physical functioning and the physical role, that plays in quality of life. Because this is where substantial weight loss, when we talk about 20, 25, 30% weight loss, this is where it makes an impact. The fact that people are able to tie their shoelaces, the fact that somebody with type 2 diabetes are now able to paint their toenails, that makes such an impact on their quality of life. And I think that is going to be one of the things that surgery will always have, this substantial weight loss that drives functionality. But now what we also are interested in is, can we start turning the clock back when it comes to complications? Now, in this 10-year study, what they were able to show is that surgery is very good to prevent the complications of diabetes. Because remember, it's not glycemia that costs money, right? It is the complications of diabetes that cost so much money to the NHS. And if we can prevent that, that is amazing. But now I actually think we can even go one step further, and we're going to talk about that later. We can start turning the clock back, which is going to be even better. So here's another amazing paper that came out earlier this year, only a couple of weeks ago, which is medicines are great at weight loss. This is the semaglutide 2.4 milligrams paper in the New England Journal, showing that on average, people achieve more than 16% weight loss. So this is really in the space what we used to with gastric banding. Right? But just as we had with gastric banding, and again, I think we need to learn so much from what we saw with surgery when we think about medicines. What we saw with surgery, and if we think about gastric banding, there were patients in your clinic and in my clinic that lost tremendous amounts of weight with the band, 40, 50% even total body weight loss. And there were other people that lost no weight. Right? There were responders and non-responders. And that is what we are also seeing with medications. Now, I want to focus your attention on the right hand of this graph. A third of patients lost more than 20% of their weight. This is genuinely a game changer. This is going to be one of those foundation drugs, like simvastatin was to the treatment of dyslipidemia, or ramipril was to the treatment of hypertension. This is really, really going to be amazing. But note that there are a substantial number of people who are very smart and treated in very good places that lose less than 10% of their weight, or maybe less than 15% of their weight. So therefore, medicines are going to be really, really good, but it's not everybody is going to achieve, are going to be responders. So again, think, the way what we learned when we treated people with gastric bands. So what do we do now? Do we now run away in horror? Are we panicking, or do we think, wow, this is a really great idea? Because remember, at the moment, we are treating fewer than 1% of the population that suffer with the disease of obesity, right? So if we are worried about medicines taking market share, if we're going to fight over the 1% of the population, I really think we're going to miss the boat. And we're missing the point completely. Now what medicine is able to do is medicine is able to increase the market size of the people who are being treated for the disease of obesity. And therefore, even if our market share of surgery goes down, our absolute numbers of treatment are very likely to increase. So please don't be one of those people that's going to fight, surgery is better than medicine. Rather think, how can surgery benefit, from what medicine is going to do when it's going to open up the market for the treatment of obesity. Because what we know about surgery is surgery works in the long term. And we know that is a real benefit. But remember also the downsides, that even with surgery, there are responders and non-responders. So there's patients who don't respond even to good treatments, such as bypass or sleeves or even duodenal switches. And that's where the medicines are now starting to fill a gap. Now, either liraglutide or semaglutide. And just to remind you that these are natural peptides, 37 amino acid structures. And with liraglutide, the company changed 1 amino acid. And with semaglutide, they changed 2 amino acids. So these peptides are behaving exactly the same as your GLP-1 that you produce endogenously after the operations. And what we can see if we think about the old drugs, this is exenatide and the half-life of exenatide, and you have these peaks and troughs, and this is liraglutide. But if we now superimpose what semaglutide will do with the 7-day half-life, you can see you have a much better curve. And therefore, in the longer term, we perceive that it's going to be far superior. Now, let's go back to the old data. Let's just look at liraglutide, 3 milligrams. This is a 3-year data in the pre-diabetes study, and you can see exactly like surgery, most people lose most of their weight in the first year, and then there's a small amount of weight to regain over a period of time. That is not failure of the drug in the same way as that's not failure of surgery. It's normal physiology. But you will also remember what happened when you took out the bands. The minute you took out a band, that patient became ravenous, right? Or even if you have been unfortunate enough to have to, reverse a gastric bypass, what you see after you reverse a gastric bypass, patients become ravenous. And that's exactly what happens when you stop the medication. So you can see people become hungry, they start regaining weight tremendously quickly, really. So what that tells us is that is a potential for surgery to help medicine, because surgery is a chronic treatment that it just happens that you as bariatric surgeons, you take it 45 minutes or an hour to do a procedure. But what you have given the patient is a perfect chronic treatment that works every time when they have a meal. And what you see here is when we stop the medicines, people will start regaining weight. So what's going to happen is a lot of people are going to start the drugs, and some people may have to discontinue it. Maybe they can't afford it. Maybe the state will say that the NHS will say you can only have it for 2 years, for example. So imagine if you are somebody that has experienced 16% weight loss and suddenly you regain all your weight. What are you going to do, right? You're going to say, listen, I would like something that can actually work in the long term. And again, just think about the gastric banding patients. When the bands came out, how many of them came back and said, please, can I have another procedure such as a bypass or a sleeve, for example? So one of the issues that we already touched on is not everybody responds after these operations. And what you can see, this is the liraglutide 3-year data. Almost 16%, 15% of patients gain weight with this medication. But if we actually look at the group that I'm most interested in, 11% of patients lose 15% of their weight. Now, that's an advantage to you and me, because many of the internal medicine doctors, I've now seen how good liraglutide is. But now imagine they're going to get a drug that's twice as good. So the amount of time that it's going to go or take for us to adapt and actually change over and start using this drug is much less than if this was a new drug that's come to market, because we have experience and we have understood why these patients do so well. So here's another good intervention. This is the direct study with a very good diet approach, a very low calorie diet, meal replacement approach. And we can see once people get 15% weight loss, you can see how they have an improvement in achieving remission of diabetes. But what you and I have seen over and over again, every time we go to clinic, we see the, people who go to the Biggest Loser. Every clinic, we have somebody that went to the Biggest Loser or, Operation Transformation, who lose buckets loads of weight. But then the problem is they regain the weight. Why? Because if you have a treatment such as the left that makes you lose weight, what will happen is you will regain that weight, because weight loss that's not physiologically driven will cause hunger. And now what we are seeing with the medications is quite the opposite. So I'm going to just remind you, if you are normal weight, the more food you eat, the more satisfied you would feel. If you have the disease of obesity, this curve has shifted to the right. So you need more food to feel satisfied. Now, if I take that person and I put them on a very low calorie diet and they do not respond to that treatment, remember they are responders, but if they do not respond to the treatment, they will lose weight. But what will happen is they will become even hungrier, right? And that's not what we need. So what we need with our interventions, be it surgical treatments, and surgical treatments are really the example of how this works, but also now the new medications, what you see is it's shifted to the left. So people consume fewer calories and therefore feel satisfied. And that's another reason why the medications are going to, in my opinion, lead to more operations, because it works in a similar physiological way. So what patients are experiencing from the medications when it works, they feel less hungry, they feel more satisfied, they're not bothered with food. The weight, they're not trying to lose weight. Remember, one of the last things that you and I tell patients in the first year after surgery is lose weight. They lose weight without trying. They lose weight because they've had an operation that works through physiology. Now we're going to have treatments, drug treatments, that's going to work even if patients are not told to lose weight. So they're going to lose weight because of physiology, not because of their own volition or how good we are telling them. So if we think about where the neurons that code for hunger and satiety, it sits in the subcortical areas of the brain. And now we are thinking of obesity as a neurological disease, not a psychological disease, a neurological disease. And what surgery does is it treats this neurology that has pathophysiological processes. And now we can come back to this principle that if you have a good diet approach that works, or good medications, or good surgery, they only work if they make people feel less hungry, more satisfied, and reduces appetitive behavior. It reduces the behavior of seeking food or looking for food. And again, that's something that we, just take for granted after surgery now. People come back and say, I've got 20% more headspace because I'm just not thinking about food anymore. We're now going to see the same thing happening with medications, right? And if we can actually explain to people that surgery and medications work on the same principles, what we will do is we'll break down the barriers to people saying, actually, you know what, I have experienced this great benefit, but I may have to stop the medication, or I've achieved 15% weight loss. How about me getting 25% weight loss, through a similar mechanism, etc. So this is the idea of the set point that is pushed up because of our environment, not enough sleep, not enough exercise, not enough good food. And what we want to push down now is, either with lifestyle changes or with the good medications or with surgical treatments. So again, the reason why I think that the new medications are going to be gateway drugs for surgery is because patients are going to experience the same physiological changes and therefore it's easy for them to effectively upgrade to go to the next level. So what do we want to do when we treat obesity as a disease? We want to address the complications such as metabolic, mechanical, and mental complications. And what we are seeing is that we can do this with surgical treatments. But what we are now seeing is we can also start achieving that with medications. And if we only have 5% weight loss, we can achieve some of it. At 11% weight loss, we're getting better, but now at 16% weight loss, it becomes a real ball game. Now, all of these things are very much known to you within the surgical space because you always have treatments that achieve more than 16% weight loss. But now we are able to actually push that with medicine to actually allow people to experience the real benefit of treating obesity as a disease, not going for weight loss, but going for health gain. And I think if we can get that narrative right, that surgery is not a weight loss treatment, that surgery is a health gain treatment, we are going to chime in very much along with what the medical companies are going to also be promoting. This is work I did with Wendy Brown in Australia, and they had a great banding cohorts, and of course they looked at the metabolic syndrome. But what you will see is more is better, right? So yes, 15% weight loss is very good, but if you get 25% weight loss, it is better, right? And that is going to be the opportunity for us to actually allow people to go, people who would never have thought about having surgery, now suddenly are going to experience 15% weight loss, but they will understand that actually they will need an extra amount of weight loss to achieve further health gain, further quality of life. And therefore you're going to find that people will effectively upgrade to the next treatment. So again, just coming to this idea, 5%, 10%, 15%, and really above 15%, that is where we start moving the needle. That's where we start getting the mortality benefits. That's where we start getting the remission of diabetes. But also, that is where we can start addressing the complications of obesity. And that, I think, is going to be very exciting to be able to achieve. So when we think, just to illustrate this point a little bit more, this is just data from the Look Ahead study. So this is just diet and exercise data, but it shows you there are people that can achieve 15% weight loss with a diet and exercise approach. So we should also stop poo-pooing diet and stop saying that diets are bad and diets don't work. Diets work. They only work in a small number of patients, but don't say diets don't work, because then people think you haven't read the literature. So it does work, but understand that it doesn't work in everybody, and therefore what we have a benefit from a surgical point of view is we have treatments that work for so many people. And also, if we now start thinking about where can we start seeing mortality benefits, it's really only when we get above 10% weight loss. Now, the reason why that is important is that we do not yet have randomized controlled studies that show intentional weight loss reduces mortality. And, we've never been able to do that with surgery because we've never been able to power a study or fund a study like that. That is now going to change, with the medication. So we will have drugs that will show that intentional weight loss, of more than 10%, 15% is likely to lead to a mortality benefit. So once we have randomized controlled trial data, that's the opportunity to actually drive that point home. Because when we look at the health economics of it, that is going to start changing the health economic models that we use when we are informing decisions from payers, be it public payers or private payers. So this is what I personally think is the next level. This is the microvascular outcomes after metabolic surgery study, the BOMSS trial done in Brazil with Ricardo Cohen's group. And what Ricardo did is he was brave enough to effectively take surgery, gastric bypass in this case, and add in good medications. So what he did is he took everybody after gastric bypass with complications of diabetes, in this case, diabetic kidney disease. So people had chronic kidney disease plus diabetes plus obesity, and he randomized them to either having best medication, so GLP-1 plus SGLT2 plus metformin, everything that you could throw at the patients. On the other side, they were randomized to surgery plus ACE inhibitors, plus statins, plus metformin, right? And what he was able to show is surgery is able to put chronic kidney disease into remission. Now, it turns out medicines are also pretty good, but surgery with medicine is better. And again, just to put that in perspective, 82% of patients with surgery plus medicine were able to achieve remission, while 48% of patients with medicine alone were able to achieve remission at that level. So medicines are good, but surgery plus medicine is better. So it's not surgery against medicine. That's a theme, I think that we need to discuss tonight. So here's what I think is going to be the most important difference, and that's going to be the mechanical benefits that we see after surgery. And we know that, you need to achieve double-digit weight loss. You need to achieve 15-20% weight loss consistently to improve functionality. And already what we saw with the Mingroni and Rubino study in the Lancet this year is we saw how important this is when it comes to driving quality of life. And I think, we will get there with medicines, but it will take a little bit longer for us to achieve consistently 25-30% weight loss as we do with surgery every day. Now, what that drives is quality of life. And remember, this is not happiness. So these new medications are not going to be skinny drugs. They're not going to make you thin or make you happy. What they're going to do is they're going to make you healthier and more functional, and that is going to drive quality of life. So I'm going to start summarizing and suggest to you that our standard treatment algorithms for chronic disease is no different to the disease of obesity. We need to start with self-directed lifestyle changes. So we need more public health messages about obesity as a disease. Obesity is a disease that needs to be prevented. And we need to have prevention strategies. We not have to tell people to be better citizens, and behave. We need to tell them this is a disease and we need to try and prevent it. Right? But if that is not good enough, if somebody develops the disease of obesity, then we have to treat it. And that's where professionally directed lifestyle changes, are important. This is effectively your tier 2 services. Now we are thinking about the tier 3 by adding medications. And, I've been on record of saying that I think tier 3 services was really a bad idea. Because it slowed people down to have surgery. We did not achieve anything by keeping people in purgatory for another year before they were allowed to have surgery. But now we may have the opportunity to actually use medications that can achieve 10, 15, 20% weight loss, in the tier 3 services, which changes it. But I still think what's going to happen is we are now going to say, listen, we've given you an excellent drug. Despite you being a very good person and despite me being the best doctor I can and the system being the best we can, this did not work for you. So now what we need to do is escalate that to surgery. And I think this is going to happen more frequently. If we get more tier 3 services that uses good medications, what we're going to find is we're going to find more of them are going to start referring for surgery. And then, of course, where do we need to go? I think we need to have a low threshold of combining therapies. And we don't have the data yet, but wouldn't it be amazing if we can add on semaglutide to gastric bypass, add on semaglutide on top of sleeve gastrectomy, and get the outcomes that we currently see with duodenal switches, without many of the downsides. That work still needs to be done. That's pure speculation. But, we are now in touching distance of actually achieving that. So I'm going to conclude and suggest medications will only improve from this point onward. But demand for surgery is likely to increase in the medium term, and combining surgery with medicines will be the future for many of us. So please allow me to thank the team at home, and especially Helen Heenahan, who's leading our surgical team, as well as Dimitri Panaris, and many of Carl Neff, one of my colleagues, etc. These are our international collaborators, you know, who have, you know, we could not have done without. And I'm very pleased, you know, to be able to answer some questions. So thank you very much.
Carel, thank you ever so much. Another really riveting talk as usual, and there wasn't that much controversy in it actually. I thought you were really, really kind. Now, lots of questions coming through, a few themes coming through. So I'll just start with the first one. In terms of patient selection and BMI cutoffs, and how do we get the GPs to prescribe expensive drugs?
Yeah. So I think the issue is that the drugs are always going to be much more expensive than surgery. You know, so we will never be able to get a drug that's going to be as cheap as surgery. And the reason is because surgery has an upfront cost, but no ongoing cost, or the ongoing cost is actually pretty low. Where the problem with the medications are, you have a chronic treatment that needs effectively lifelong treatment. So it's going to be difficult for the companies to get the sweet spot where they meet the so-called ICER, or the cost per quality data. Now, that's probably going to be possible for patients with complications of obesity. So that's why we have liraglutide in the NHS. And, you know, again, NICE has been leading the world, you know, being the first public payer to agree to it. But that is focused on people with obesity, BMI over 35, with pre-diabetes. Now, this drug is twice as good as liraglutide, and what I really hope is that it will reduce the BMI cutoff to maybe a BMI above 30, but whether or not it will also require pre-diabetes or other complications, it is likely to be that, in my opinion, but, you know, I think the data still needs to be crunched.
Okay. And the place of prescribing drugs like semaglutide is in tier 3, so tier 3 will prescribe it.
Yeah. So I trained. Yeah. Sorry.
Will these tier 3s take up sort of that role?
Yeah. So I started life training as a lipidologist, and I remember when statins was a hospital drug only, you know, and you know, very soon what we saw is statins were safe, they were very effective, and, you know, if you were at any level of training, you could prescribe it very safely, and that is what happened. So now today, statins is a general practitioner drug. So I think, you know, likely that these medications are going to run the same road. You know, we're going to start with tier 3, probably in hospitals first. Then hopefully we're going to get it to tier 3 in the community. And then hopefully it will start becoming a general practitioner medication. Just as statins have done, or, you know, I remember, you know, when we did the captopril test, you had to come to hospital to get an ACE inhibitor to see whether or not we're going to kill your kidneys, you know, and now, of course, we're just dishing out ACE inhibitors because they're so safe and so effective. So I think we're going to run the same road, but it will be stepwise. And the problem is that the governments are really concerned about treating 25% of the population that they've never had to treat before. And we have to have sympathy with the NHS. You know, we can't bankrupt the NHS, you know, because treating obesity is an important thing. You know, in the same way as we did with statins, you know, we started treating people with established heart attacks and total cholesterols of 7. That's where we started. And then when the data came out and we treated primary prevention, you know, so we have to be responsible as well. Otherwise, we'll get too much pushback.
Okay, Carel, another question we've had linked into this anyway is, we know, as you mentioned in your talk, there are always going to be non-responders, and I think with GLP-1 agonists, we're probably looking at maybe an expected 15% of patients who will be non-responders to that line of treatment. And so if we were looking at a strategy where we tried medications and then moved on to surgery, is there not a concern that the non-responders would have been better going for surgery in the first place, or are they likely to not respond to the physiology that surgery induces as well?
So I think if somebody wants surgery, they should go and have surgery. You know, there's no point in making them take the medication first to prove that they are a non-responder before they can go to surgery. But where I'm thinking is the patients who've never thought about having surgery. Right. So these people would never have gone to surgery. And now they may be prepared to take a medication. Now, remember, people aren't lining up, outside in the street to inject themselves once a week with a medication. That's not as if people are falling over themselves to sign up for that, but there will be people that will at least be able to do that. And I think if you have taken that step, you've taken the medication, and you maybe have lost 10% of your weight, you may still be a responder, but now you will think, actually, you know what? This is so good. Imagine what life would be like if I've got 25% weight loss. There will be a proportion of people that will say, 10% is fine, job done. But they would never have gone to surgery in the first instance. So I don't think we're losing out anything. But I want to be very clear. I do not think it is sensible to stop somebody having surgery, make them take a diet first, make them take a drug first, and then only go over to surgery. That's not good medicine.
Okay. We've had a few questions, Carel, about the place of medications like semaglutide in weight regain following surgery, and in patients who are potentially seeking revisional weight loss procedures. So what place can you foresee these medications will have in the management algorithm of these patients?
Yeah. So that's something that really surprised me. And it was Alex Meares that did the Gravitas study together with other UK colleagues who showed that if you combined low dose liraglutide, 1.8 milligrams, with surgery, you actually had better glycemic control and better weight loss, right? And I would genuinely not have predicted that. But that's the data. So what we are seeing now is, say, for example, you're a non-responder to surgery. So, for example, you only get 15% weight loss with an operation. That does not mean you're going to be a non-responder to the medication. It also doesn't mean you will be a responder to the medication. But we can usually tell within 3 to 4 months whether or not somebody responds to the drug. So the opportunity is going to be in people who either have weight regain or in people who are primary non-responders to surgery, that we're going to be able to add medications, to them to achieve long-term weight loss maintenance. Now, in my clinic, I'm an enthusiast, so maybe I'm an outlier, but maybe 1 in 3 patients in my clinic, are in a combination of surgery plus medicines. Because what we want to do is we want to achieve maximum health gain. So we really want to maintain 30% weight loss in the long term. The benefits of both surgery and GLP-1 treatments are that they have effects beyond weight loss, right? So we see even people that don't lose any weight with liraglutide, they also have an improvement in glycemia. Right? And people, of course, who lose a lot of weight have an even bigger improvement in glycemia. Same what we see with surgery. So if we can combine those treatments, I think there's going to be benefits. But it's not only semaglutide. Semaglutide is the flavor of the month, rightly so today. But there's going to be a host of new medications that is going to complement what surgery does. And of course, the future is going to be when we're going to combine the medications. So that is going to be very exciting.
Could non-response to semaglutide predict, do you think, non-response to a surgical operation?
So nobody has tested that formally yet, but the suggestion would be at the moment that no is the answer. So if a patient did not respond to the drug, that does not mean they will not respond to surgery. And therefore, because, and that's another benefit, if you think about it, again, think about bands and bypasses. What we had with bands were like sniper rifles. They had a limited number of mechanisms, but when it worked incredibly well, right? But what you have with a bypass or a sleeve is you have a shotgun approach. So you have, you've got a GLP-1 that's up, the bile acid has changed, the microbiota has changed, you have changes in vagal signaling. So again, that's why surgery is so good. So surgery is the perfect concert of mechanisms in play. Now we're going to try and mimic that by combining different medications, and we will be able to achieve 35%, 40% weight loss, even with combining medications in future. But what I don't think we'll be able to do is do it that consistently. So there will always be non-responders. And, so if you, and I just come back to the lipid clinic example, where I started my life in a lipid clinic, seeing primary people with primary prevention, for dyslipidemia. Today, if you go to a lipid clinic, the only people you see are people who are statin intolerant. right? So the lipid clinics are still full, they're still busy, but they are busy with people who are not responding to the treatments, you know, that are being used in primary care. And I think that is what's going to happen with surgery as well, as we have better treatments.
So Carel, we've had a few questions about BMI thresholds, and we know that for the GLP-1 agonists, they could be as low as around 27, 27.5 with comorbidity. So if these drugs are producing kind of similar levels of weight loss to surgery, this puts a pressure on us to reconsider the BMI threshold for surgery, given that current modern bariatric surgery has a mortality that's slightly less than a laparoscopic cholecystectomy.
Absolutely. You know, there's no physiological reason and there's no safety reason why we cannot, you know, have surgery for people with a BMI of 27, you know, or 30, for example. You know, and we already have that for type 2 diabetes, right? And we see that if you operate on people with type 2 diabetes that have a body mass index of 31, you know, none of them become underweight or malnourished. In the same way as people don't become malnourished if you operate on them with a BMI of 45. And we're going to, but that's a flip side as this as well. Getting 20% weight loss with a drug, right, is not only good news, right? So the physicians who treat, you know, who are going to treat people with obesity for the first time with medication, who don't have any experience of looking after surgical patients, are going to be shocked, if I want, you know, for the problems that it's going to create. Okay, so the stuff that we deal with on a surgical basis every day, they're going to see for the first time, and we'll have to hold their hands to allow them to understand that 20% weight loss has massive benefits, but it has the same challenges that 20 or 25% weight loss has with surgery. You know, suddenly people are going to, you know, people use food as emotional regulators. When they're happy, they would eat, or they're sad, they would eat. We know that with surgery. So what happens now after you have an operation and you can't eat when you're happy or sad? You may sometimes do different stuff, right? And sometimes that's bad things. The same thing is going to happen with 20, 25% weight loss with a drug. You know, so we have to help the physicians to understand that it is okay, and we have, you know, ways to solve it. You know, they're going to start seeing gallstones, you know, that they've never thought about, you know. And again, so I think, you know, just working closer together is going to be the right thing to do, as it's always been. So we need to help them and hold their hands, you know, especially those physicians that haven't seen bariatric surgery patients.
It's great you mentioned about the sort of psychological element of this, because we've had a few comments come through about using, when these medications are licensed, they should be used along with psychological support for patients, so that, you know, those aspects and factors are also dealt with, Carel. Now, we've also got a couple of patients who've had weight loss surgery listening into the webinar tonight, which I think is fantastic. So there's been a question about, for example, a patient who's had a gastric bypass 2 years ago and their weight's stable, they're no longer losing weight, but they haven't regained weight. Do you think these sort of medications should be used to prevent weight regain in weight stable patients, or should we wait until they have regained weight? What's the role there?
So we know that the vast majority of people after surgery do not regain weight. Okay. Of course, my clinic are full of people who regain weight, because that's what I see, right? So I have a skewed view of the world, but the vast majority of people lose weight and maintain weight in the long term. And it's like anything, you know, don't use any medication if it's not going to be particularly helpful. You know, the medication will have to have a purpose. So using these medications as prevention, you know, that is not being tested. But what I would say, for example, you plateau at 25% weight loss, but your complications of obesity have not been reversed. You know, then I may consider adding this medication to achieve 30 or 35% weight loss, if I think that additional 10% is going to give me a reversal of complications. But remember, like anything, it's the law of diminishing returns. Just because you lose an extra 10% weight loss, the first 10% is where you have the most benefit. The next 10% you get super benefit, and then there's the law of diminishing returns. So We need to be sensible with this. These are going to be expensive medications. They're going to be good drugs, but they will have side effects, right? So we don't want to do anything that's going to put the medications at risk. Because we've had good drugs in the past. We had rimonabant, we had sibutramine. These were good medications for obesity, but we lost them because we were greedy, or we didn't use them in the right way, or we allowed patients to get a lot of side effects without maintaining the benefit. So we need to protect this drug to make sure that we have it in the long term.
So, Carel, I think I'm going to wrap up the questioning. You'll be pleased to know. I think we've had a lot of questions about weight regain, and it seems to be like a theme that people are thinking this is potentially a great area for these drugs and surgery to work in partnership and synergy with each other. You've got an amazing reputation for some of the basic science work you've done that's really enhanced our understanding of why bariatric surgery works. And my question is, we often tell patients when we counsel them before surgery that we know that the beneficial effects of surgery, particularly the gut hormone effects, are going to fade with time. They will wane. There's a honeymoon period in that first year or so, and then their body is either going to adapt to the gut hormone changes, or they're going to sort of diminish. And my question is, from a physiological point of view, is it that gut hormone production, if you like, generated by surgery starts to tail off with time, or is it that you get almost like a resistance, a tissue resistance to the effect of the GLP-1 and the other gut hormones as time goes by, that the body adapts in that way? And therefore, reflecting that back on the GLP-1 agonist drugs, if it was a lack of production with time, then you could see a very logical argument for then kicking in with a GLP-1 agonist to top up the levels the body is not producing so much of these days. I mean, can you give us some feel about is that too simplistic a view of the physiology? How does it work?
Yeah, so I think it is, somebody said obesity is not rocket science. It's far more complicated than that, so I think that's a good place to start, to say that, there are patients who, for example, do have a weight regain, and it may have to do with attenuation of gut hormone production or even receptor response, but, that's very controversial. What we will see is that the majority of people with this medication will be able to lose weight and maintain weight in the long term. But there will be, in the same way as with surgery, there will be some patients that will start regaining weight. And that's probably because they just have a different type of obesity, where this is not the major problem that's being solved, or this is not the major trigger that's being pulled. And again, what we see that in surgery, but we don't see that frequently, relatively speaking, because surgery has more than one mechanism. And that's what I think the medications will do, is we'll have more than one drug in combination. But again, by combining the drugs with surgery, I think we're going to be able to overcome that in the longer term. So it is early days. It's absolutely speculation, David, and I take your point. But, that's why we just, that's why I'll stay in a day job for a bit longer, trying to work this stuff out.
Yeah, we'll all be glad if you do.
Carel, thank you ever so much. It's been a really, really insightful and fascinating and really fantastic Q&A session. So thanks for presenting to us this evening. Thank you all for attending. Another plug for the next Journal Club on the 10th of March at 8 p.m. Thank you very much. Good night.